Welcome to the second section of our course, where we explore the world of clinical classification systems focusing on ICD-10-CM and ICD-10-PCS. In this lesson, you will learn the rules, structures, and guidelines for assigning diagnostic and inpatient procedure codes. This is incredibly important because these code sets form the absolute core of your daily work as a medical coder and make up a massive portion of the certification exam. I am so excited to demystify these code books for you and show you exactly how to translate complex medical terms into universally understood numbers and letters. Get ready, because mastering this section will give you the confidence you need to tackle the most challenging coding scenarios. Let us start with the ICD-10-CM, which stands for the International Classification of Diseases. 10th revision. Clinical modification. This specific code set is used to report medical diagnoses and the reasons why patients are seeking healthcare services. Whenever a doctor determines what is wrong with a patient, such as diagnosing them with asthma or a fractured arm, you will use the ICD-10-CM book to find the exact code for that condition. Every single healthcare setting, from a small family clinic to a massive hospital, uses this exact same diagnostic system. Understanding the purpose of ICD-10-CM is the absolute foundation of all medical coding. The ICD-10-CM codebook is divided into two major sections that you must navigate in a very specific order. The first part is the alphabetic index, which is a massive dictionary of medical diseases, conditions, and injuries listed in alphabetical order. The second part is the tabular list, which contains the actual alphanumeric codes organized sequentially by body system or disease category. You will always look up the medical term in the alphabetic index first, and then you must verify the code you find by checking the tabular list. You should never assign a code based on the alphabetic index alone, as this is a common trap that leads to incorrect coding. Let us look closer at the structure of an actual ICD-10-CM diagnosis code. These codes can be anywhere from 3 to 7 characters long, starting with a letter followed by numbers or sometimes other letters. The first 3 characters represent the category of the disease, providing a broad overview of the patient's condition. The remaining characters add very specific clinical details, such as the exact location of the illness or the severity of the disease. For your exam, you must remember that a code is only considered valid when it is coded to the highest number of characters available for that specific condition. As you flip through the tabular list, you will quickly notice special symbols and instructional notes known as coding conventions. These conventions are the strict rules of the road that tell you how to correctly apply the codes. For example, an includes note gives you further examples of conditions that fit into a specific code category. Conversely, an excludes note warns you that certain conditions cannot be coded together under any circumstances. Understanding and obeying these instructional notes is absolutely critical for passing your exam and preventing claim denials in the real world. One of the most important concepts in diagnosis coding is understanding the difference between a principal diagnosis and a secondary diagnosis. The principal diagnosis is defined as the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Simply put, it is the main reason the patient was admitted to an inpatient bed. Secondary diagnoses are all the other additional conditions that the patient has that affect their care or treatment during that specific hospital stay. Correctly sequencing the principal diagnosis first is a major focus of the certification exam. You will often encounter situations where a patient comes in with a symptom, like severe abdominal pain, but leaves with a confirmed diagnosis, like appendicitis. The coding guidelines state that you should code the confirmed diagnosis and not the symptom. Symptoms that are an expected and natural part of a disease are already built into the main disease code. However, if a patient has a symptom that is completely unrelated to their confirmed diagnosis, you would code that symptom separately. This rule prevents redundant coding and ensures the insurance company gets a clear picture of the patient's actual illness. Another common scenario you will face is coding for acute and chronic conditions. An acute condition is severe and comes on suddenly, while a chronic condition is a long-term illness that develops slowly over time. If a patient has both the acute and chronic forms of a single disease, and the coding manual provides separate codes for each, the rules state you must sequence the acute code first. For example, if a patient has acute and chronic kidney failure, the acute failure is the more urgent problem and is listed as the primary code. The exam loves to test your knowledge of how to sequence acute versus chronic illnesses. Now let us switch gears and talk about the other half of the inpatient coding world, which is the ICD-10-PCS code set. PCS stands for Procedure Coding System, and it is entirely different from the diagnostic system we just discussed. ICD-10-PCS is used exclusively by hospitals to report the surgical and medical procedures performed on inpatients. You will not use this book for clinic visits or outpatient surgeries. Remembering that PCS is strictly for inpatient procedures is a fundamental rule that you must memorize for your test. The structure of an ICD-10-PCS code is very rigid and completely different from a diagnosis code. Every single PCS code is exactly 7 characters long, and each character has a very specific and unchanging meaning. The characters represent details like the body system involved, the root operation performed, the specific body part, the surgical approach, and any devices left inside the patient. Because every character has a defined purpose, you can actually build a PCS code character by character using the specialized tables in the manual. To build a PCS code, you must first consult the PCS alphabetic index to locate the table associated with the procedure. However, the index does not give you a complete code like the diagnosis book does. Instead, it directs you to a specific table composed of rows and columns containing different character options. You must stay within a single row of that table to select the remaining characters needed to complete your 7-character code. Crossing rows within a table is strictly forbidden and will result in an invalid code, which is a favorite trick question on coding exams. The most challenging and important part of PCS coding is identifying the correct root operation. The root operation is the core objective or the exact medical goal of the surgical procedure. There are 31 different root operations in the medical and surgical section, such as excision, resection, bypass, and inspection. An excision is cutting out a portion of a body part, while a resection is cutting out the entire body part. Knowing the precise definitions of these root operations is the absolute key to successful inpatient procedure coding. Another critical character in a PCS code is the surgical approach, which describes exactly how the surgeon reached the site of the procedure. There are several different approaches, including open, percutaneous, and percutaneous endoscopic. An open approach means cutting through the skin and tissue to expose the site, while a percutaneous approach means entering by a minor puncture or tiny incision. Correctly identifying the approach from the surgeon's operative report requires careful reading and a solid understanding of surgical terminology. The device character in ICD-10-PCS is used to identify specialized equipment that is intentionally left inside the patient's body after the surgery is completed. Examples of devices include a cardiac pacemaker, a joint replacement implant, or a surgical mesh used for hernia repair. If a surgical instrument is simply used during the procedure and then removed, it is not considered a device and is not coded. You must pay close attention to the operative report to determine if an implant or device remains in the body long after the surgery. Coding for combination procedures is another area where students often get confused. Sometimes a surgeon starts a procedure using a minimally invasive approach, like a tiny camera, but encounters a complication and has to convert it to an open surgery. The coding guidelines explicitly state that you must code both the diagnostic camera procedure and the final open surgical procedure. This ensures the hospital is fully recognized for all the time and resources spent in the operating room. Make sure you understand the rules for procedures that are started but not completed, or converted to a different surgical approach. Both the diagnosis and procedure code sets utilize placeholders, specifically the letter X, to allow for future expansion of the codebooks. In diagnosis coding, the letter X is often used to fill empty character spaces so that a required seventh character extension can be placed in the correct position. For example, if a code requires a seventh character to indicate an initial encounter, but the base code is only 4 characters long, you will use 2 X placeholders in the 5th and 6th spots. The letter X acts simply as a placeholder and has no clinical meaning itself. To ensure everyone codes correctly, the healthcare industry relies on the official guidelines for coding and reporting. These guidelines are the absolute law of the coding profession and are approved by the federal government and major health organizations. The guidelines provide extremely detailed instructions on how to code complex scenarios, such as obstetrics, newborn care, and systemic infections like sepsis. You do not need to memorize every single guideline, but you must know how to quickly find and interpret them during your open book exam. An essential exam strategy is to thoroughly tab and highlight your coding manuals before test day. Creating a personalized navigation system using sticky notes for major body systems or tricky guidelines will save you massive amounts of time during the exam. Since you are taking a timed test, the ability to instantly flip to the correct section is just as important as knowing the coding rules. Professional coders use tabbed books every single day to maximize their speed, accuracy, and overall efficiency. Remember that clinical coding is essentially a translation job, requiring a strong foundation in anatomy and medical terminology. You cannot assign the correct code for a fractured distal radius if you do not know that the radius is a bone in the forearm. Spend time reviewing basic body systems alongside your coding practice. because the exam questions will use formal medical language to describe patient conditions. The better you understand the clinical side of the documentation, the easier it will be to navigate the complex classification systems. Congratulations on successfully completing the second section of this course. You have just absorbed the foundational rules for the two most critical coding systems used in inpatient healthcare, which is a major accomplishment. I strongly encourage you to complete the attached practice test for this section right away. Completing practice questions is proven to dramatically improve your long-term retention and exam readiness. The practice test is included with this lesson to ensure your success. Keep up the fantastic active learning. And I will see you in the next section where we will explore outpatient procedural coding.